I want to welcome everyone who's here. Thank you so much for coming to this exciting conversation between two experts. I'm Anne Fulenwider. I'm one of the co-founders and co-CEOs of Alloy Women's Health. We are a platform aimed at women suffering from the symptoms of perimenopause and menopause. We provide education, access to expertise, and solutions that really work. And we are thrilled today to have our Chief Medical Advisor, Sharon Malone, and renowned neuroscientist, Dr. Lisa Mosconi, both of whom have books. I'm going to try to show you. This is Dr. Lisa Mosconi's new book, The Menopause Brain. And this is Dr. Sharon Malone's new book, Grown Women Talk, both of which have come out in the past month. And both these experts have been touring the country, if not the world, sharing their expertise. And I will do quick intros of each of you and then quickly get into all the questions we all have about menopause and the brain. I'll just read Dr. Sharon Malone's bio. Dr. Malone is a nationally known expert in women's health and the author of Grown Women Talk. She is the Chief Medical Advisor at Alloy Women's Health, and she was a partner at one of the oldest and most successful OBGYN medical practices in Washington, D.C. She's board certified by the American College of Obstetricians and Gynecologists and certified by the North American Menopause Society as a certified national menopause practitioner. Throughout her professional career, she's been active in advocating for reproductive rights, reducing teen pregnancy, and eliminating healthcare disparities. Dr. Lisa Mosconi is an Associate Professor of Neuroscience and Radiology at Weill Cornell Medicine and the Director of the Women's Brain Initiative and Alzheimer's Prevention Clinic at Weill Cornell Medicine, NewYork-Presbyterian Hospital. A world-renowned scientist with a PhD in neuroscience and nuclear medicine from the University of Florence in Italy, Mosconi was listed as one of the 17 most influential women scientists by the Times and called the Mona Lisa of neuroscience by Elle International. She's the best-selling author of The XX Brain and Brain Food, and her new book is The Menopause Brain. We have a lot to discuss. Welcome. Thank you for coming.
Thank you. Thank you for having us.
We're thrilled, and we have so much to cover. I'm going to really just quickly start by asking each of you why you entered the fields that you did in 30 seconds or less, and why this book and why now. Dr. Mosconi, would you like to go first?
Sure. So I literally grew into science. My parents are nuclear physicists, and I was always really a weird child, if you will. I was always really interested in the brain and brain health and neurology and whatnot. So I was able to get into nuclear medicine, which is a branch of radiology that specifically looks at functionality and biochemistry in different organs, including the brain. And as part of my PhD, I transferred to NYU Medical, where I was then hired as a faculty member. And I would say the major focus of my research has been on the early detection and prevention of Alzheimer's disease and neurodegenerative dementia. And more recently, I got kind of pulled into the menopause field, in part because my research shows how important and impactful menopause is for women's brain health. Why? Because when
yes. There's a hint there.
That was easy, 30 seconds. Well, this book, because the research is new and there's a lot more research being done on menopause and brain health, which I named my book after as The Menopause Brain. And I thought it's really so important to take the research out of the lab and make it not just accessible, but actionable in a way that is rigorous at the same time. Because now that menopause is having a little bit of a moment, there are a lot of things being said about menopause and always about the brain. And so I wanted to make sure that women have access to rigorous scientific information that also is not all gloom and doom. There's something positive about going through menopause that I think we should be aware of.
Dr. Malone.
Okay. Well, thank you. And I'm so delighted to be joined by my friend, Dr. Lisa Mosconi. Let me tell you, I've had a rather circuitous route to where I am now, but actually it started with the brain. Actually, when I was in college, I was a psychology major, but I was actually in psychobiology or physiological psychology because I was fascinated with all the things that were going on in the brain. And this was a long time ago. So it was just when we were figuring out it's the brain, not the mind, that is really the seat of a lot of the, really the psychiatric disorders that we found. So I went to medical school actually thinking that I was going to be a neurologist. And my advisor was this woman, this amazing woman, Dominique Toron-Ollerand. What a great name, right? And she was a neurologist, and she did her research on the effects of estrogen on the development of neurons, and how, you know, putting estrogen in a petri dish actually changed how brain cells actually grew. So that was where I kind of started. That was my initial place. And then I got to my neurology rotation, and what I thought was a fascinating field, and still is, what was depressing to me about it was no matter how smart you had to be to figure it out, because this was prior to CAT scans, people. There was a time when you couldn't just go in and get a CAT scan to figure out where something was. These neurologists were really smart people. And what really took me away from neurology was, even after figuring it all out and being the best clinicians and diagnosticians in the world, you would get to the end and you'd say, okay, now what are we going to do about it? And there were so few treatment options for what to do with people with Alzheimer's, with Parkinson's, with strokes. And so I said, oh, well, that's really a good academic exercise. But I got into OBGYN ultimately because there were very concrete things that we could do. You know, you knew what the problem was. More often than not, people were healthy and happy, and you were going to get to a good ending. So I have come full circle on this, to come back and to get to menopause and to find out that it is not just an event. It is not something that happens to women and then you move on and you're on to something else. It is a distinct phase of women's lives that we have not paid attention to, I think, from beginning to end. And thankfully, that as we've come full circle, that now we've got, you know, the brilliant Dr. Lisa Mosconi, who is finally trying to answer some of the questions that we had 40 years ago when I started medicine, because it's not okay just to describe it. Then we have to figure out, okay, well then what's the physiology? What are we going to do about it? And that's why I think that ultimately our connection has been as strong as it is, because we both are looking at menopause from different perspectives, but our goal is still the same, which is to make women age more healthfully and more functional.
I think that's beautifully said. And, you know, as we age, women, we all enter menopause if we're lucky enough to live that long, and we all start to worry about our brains. And so I'm really excited to dig into that a little bit later, what menopause does to the brain and what we can do to prevent cognitive decline. But let's start sort of with elementary. Let's have Dr. Malone, from the OBGYN perspective, just give us a baseline definition of menopause and how we treat it.
Sure. Baseline definition of menopause, which is what everybody's taught in med school, is that menopause is when you've had your last menstrual period, and it is confirmed by not having another menstrual period for 12 months. Well, okay, well, that's an event. But what we didn't know a lot about, and we didn't talk a lot about, was the transition to menopause. And that's a very long process. That is not an event. That is a phase that can take years, anywhere from 4 to 10 years. For African-American women, it's closer to the 10-year mark. And it is marked by all the symptoms that we associate with menopause. They don't just happen once you've had your last menstrual period. They start as early as the decade before. And what we are finding, and what I have been doing for the past 30 years, is figuring out how to treat those symptoms of menopause, which can be quite devastating for many women and bothersome at best. And those are hot flashes, mood swings, brain fog, all those 34 symptoms that women have. But I think that the misconception has always been is that it starts at menopause. It doesn't start at menopause. It starts a decade or so before you've actually had your last menstrual period. So the good news is that, we are now coming around to this definition, and women are understanding that to seek care and what does treatment look like. Menopause is a hormonal event. Perimenopause is really characterized by vast fluctuations in your hormones. They're up, they're down, and everywhere in between. Menopause is really defined as the moment at which your hormones, your ovaries have stopped functioning, stopped producing estrogen and progesterone on their own, and you will remain low from that time forward. So it sort of makes sense that when we are looking at treatments and how to deal with a hormonal process, that hormones actually are part and integral to that problem. So hormone therapy, either in perimenopause or menopause, is really the keystone because it is the most effective treatment for the symptoms of menopause. And as we'll hear from Dr. Mosconi, also important for preventing some of the long-term consequences of that estrogen deprivation as we age.
Beautiful, and thank you. And I think I heard you speak last week about, we all know this here on the call, but that those bothersome and sometimes more than bothersome symptoms are not benign. Just ignoring them and sort of gritting your teeth or bearing through it, it has long-term effects.
Absolutely.
So I think that brings us right to Dr. Mosconi. How do you define menopause as a neurologist, and what have you learned about the connection between menopause and the brain?
So what I've learned is that in medicine, we base the definition of menopause on the OB/GYN definition, which is very ovary driven. And that makes sense, if you're an OB/GYN and you study that kind of reproductive system. But if we look at the entire woman's body as an organism, rather than a number of different organs that work independently from each other, which they do not, that menopause is a little bit more complex. And the timeline is actually different and speaks more to what Sharon was just talking about. So menopause, from a neuroscientific perspective, is defined as a neuroendocrine transition state. This is specific to women and culminates in reproductive senescence. However, at the same time, it impacts multiple organ systems. So what does this mean? It means that we as women were born with a neuroendocrine system that connects the brain, the neurological system, to the ovaries and the rest of the endocrine system. Now, this system is turned on at puberty, is overactivated during pregnancy. Every time a woman is pregnant, is a little bit it goes through a turbulent state postpartum every time a woman has a baby, and then it's partially deactivated after menopause. But what really matters the most for this transition is the perimenopausal window, which from the brain's perspective is even longer than the 4 to 10 years that we believe it lasts based on symptoms like hot flashes and whatnot, but also really that 4 to 10 years window is based more on cycle frequency and menstrual cycle frequency. But if you're a brain, the transition for you actually starts even earlier than that. And by doing brain imaging, which is what I do for a living at this point, you can see the very subtle changes in brain structure and function and biochemistry are evident already during the late premenopausal stage, which is when women are basically in their early 40s and your period is just changing a little bit, but it's still quite regular. Your brain is already starting to get signals from the ovaries that we need to prepare for this transition. And once the ovaries are done, like Sharon was saying, the ovaries may close down shop. They stop making estrogen and progesterone, they run out of follicles. The brain is not done yet. It takes the brain another decade to really, it can take up to a decade to really settle down and find a new normal and carry on. And what we and others have shown is that the outcomes vary from person to person. So the brain symptoms of menopause, like the hot flashes, the night sweats, insomnia, depression, anxiety, the brain fog, the memory lapses, those are neurological signs that the brain is undergoing a transformation along with the ovaries, but the timeline is different. And that's why many women still have symptoms up to a decade after the final menstrual period, which really speaks to prevention and treatment when needed, because the whole process can last up to pretty much 20 years, right? And it's something that we just never talk about. And sometimes they have consequences even further ahead in the future, especially when it comes to brain aging and possible neurological disorders that come from the aging process or other pathological conditions like Alzheimer's disease. It's a bit of a nightmare, honestly. I mean, when I was studying neuroscience, and I've been working in neurology for over 20 years, and nobody ever talked to me about menopause. And I'm a woman on top of being a scientist. And all the research, I had to do the research by myself. I bought a bunch of textbooks, neuroendocrinology, endocrinology. I downloaded hundreds and hundreds of papers. And that was in 2014, 2015. And everything was basic science. There was hardly anything done on women.
Right.
And I find this so strange.
Well, I
don't find it strange. I find it unfortunate.
Yes, right.
Yeah.
I mean,
Yeah.
women's health has been so ignored.
Yeah.
And the stat that a lot of people are out there talking about now is that we were not even mandated to, our bodies, women's bodies were not even part of clinical trials until 1993. And even since then, they have barely been included. But you said something really interesting.
Do you know when estrogen was actually discovered to be a brain hormone and not just a fertility hormone? 1996.
Wow. So this is really interesting. You said something that I love, which you said brain symptoms of menopause, which everyone thinks, oh, brain fog. But you said brain symptoms of menopause, such as hot flashes. And we don't think of hot flashes as being a brain symptom.
So many patients coming to us saying there's something wrong with my skin. That's why we were talking about this before, right? People ask me about their skin. It's like, it's not your skin. It's actually the brain that fails effectively at regulating body temperature. Body temperature comes from the brain, not from the skin. So it's a neurological function in part.
And you have those famous pictures, which I know but there's the brain before menopause and the brain after menopause. Can you give us a little overview of what that means? Are our brains just declining rapidly once we hit menopause and that's it?
Well, I wouldn't say declining from a clinical perspective. So when we started investigating menopause, we started using brain imaging because it had never been done. So all the brain studies that were available back in 2014, 2015, were all done after menopause. Like Sharon was saying before, that menopause is kind of like identified as the end of your menstrual cycle, and especially in brain imaging research, all the work had been done on women who were postmenopausal, and by a long shot, like women who were in their 70s and 80s. So we really didn't have any information about how menopause directly impacts the brain and how the brain changes during the transition, which I think is much more interesting than what happens 30 years later, right? If you want to understand menopause. And so we did brain scans on midlife women, ages 40 to 65. And so we have two sets of those brain scans. The original set, which Sharon has seen multiple times at this point, shows two different women, the premenopausal women and the postmenopausal woman. And what we see, now we have hundreds and hundreds of people in the study, we see that many things differ according to menopausal status. But now we also have longitudinal data. So we can track brain changes in the same woman over time. And what we've learned is that menopause changes the structure of the brain. It changes metabolic activity in the brain, which means energy levels in the brain. It changes the connectivity of the brain, it changes blood flow to the brain, and it changes the biochemistry of the brain as well. So it's really a bit like a renovation project on the brain, where so many things change. The brain is rewiring to prepare women for a non-reproductive stage of life, right? And that is associated with multiple changes that may be associated with the symptoms. And this is what we're studying now, brain fog. What are the actual brain correlate of brain fog? And yeah, I mean, it's something that we need to better characterize for sure.
And Sharon, you have mentioned multiple times in talks that I've seen you at recently, the this idea that a hot flash is not just a pain in the neck. It actually, the more you hot flash, the more you have markers, right, for
Right.
things that will affect you later in life. Can you talk a
Right.
little bit about that?
Yeah, and let me back up a little bit, and and this brain estrogen or this brain reproductive life function and how they are correlated. There are certain things that it, but you didn't know you knew it. And now that you look back, you're like, of course, why didn't we ever think that why did we not know that there was a correlation between what goes on in your brain and what's going on with women from a reproductive point of view? And it starts in utero. The presence or absence of estrogen while you are developing as a fetus really influences how that female brain is organized versus how a male brain is organized. That, again, the presence of estrogen, it changes your brain at puberty. It changes, during your menstrual cycle. You feel differently premenstrually than you do after your menstrual cycle, during pregnancy, postpartum depression. So there's a through line that, with the presence of or absence of estrogen, that really has influences what a woman's mental state is at that particular time. And again, a mental state that we would attribute to women just being, hysterical, or you're being emotional, and not really understanding or acknowledging the fact that, no, these are changes that are going on in your brain with the presence or absence of estrogen. So when you get to perimenopause and menopause and you start having hot flashes, well, hot flashes are a manifestation of really something that's going on in your brain, and it is the connection between the presence or absence of estrogen in what is the part of your brain that regulates temperature regulation. So estrogen sort of calms that down. When your estrogen levels are sort of either low or erratic, it throws your thermostat almost off. So your brain is giving the signals to your body, hey, cool off, as if it were 90 degrees outside, and it may actually be ambient temperature, maybe 50. So all of these things that we sort of think of as being the physical manifestations of menopause originate in the brain. And that includes, like I said, depression, anxiety, hot flashes. And the reason why hot flashes, because they're the most common symptom that's really associated with menopause, the reason why they are not benign is because we know that women who have very severe hot flashes and they last for long, there are certain correlates. Women who have hot flashes are more likely to have cardiovascular disease. Women who have severe hot flashes are more likely to have depression. Women who have hot flashes, and I think, Dr. Mosconi, you can back me up on this, is that when they look at what are called these hypointense lesions in the brain, that may be, and I say may be, markers of, Alzheimer's or disease down the road. They are higher in women who have had symptoms, very severe symptoms. And who has the most severe symptoms of all? African-American women. Their hot flashes and their vasomotor symptoms tend to start earlier, they last longer, and they're more severe. And you know what? When Dr. Mosconi said this, I said, you're absolutely right. We talk about the 10 years of symptoms during perimenopause, but then there are women who will have symptoms for another 10 years after menopause. And that's a long time for women to be to sort of have these negative health consequences. If you have hot flashes, you can't sleep. If you can't sleep, that also is affecting your brain, your heart disease. all of this, it's none of this that what we talk about between the physical symptoms of menopause and the neurological symptoms, they're not unrelated. So even though we laugh and people make fun of hot flashes and say, go get a fan and it'll be fine, what we're trying to get women to understand is that they're not benign. They sometimes can be harbingers of things that are more problematic down the road. And I think that it's safe to say that it's safer than not, if you are bothered by hot flashes, to treat those hot flashes. And what's the most, effective treatment for hot flashes? Hormone therapy. And I think that women shy away from it or think that hot flashes are just something to be endured, that once you get over them, then we're done. No, you're not done. As Lisa says, these changes, this sort of remodeling project that's going on in your brain is going on whether you have hot flashes or not, but more severely in women who are more symptomatic.
And Dr. Mosconi, you have called estradiol in your book the CEO of the female brain.
Yeah.
I love that.
Yeah.
Can you explain why? And perhaps, if it's not too much to ask, kind of explain along the way a little bit more about the 3 Ps. And I love the connection between puberty, pregnancy, and perimenopause, partially because I have the pleasure of being in a house with two pubescent teenagers while I myself am going through perimenopause very quickly into menopause. So all of these hormonal stages.
So my daughter is already thinking about puberty, in part because she's always involved in whatever I do on my talks. And we calculated that by the time she goes through puberty, I may be starting peri. And my husband was like, I'm out of here.
But there's always estradiol. So why is estradiol the CEO of the brain, of the female brain?
Yeah, so in neuroscience, estradiol has been named the master regulator of women's brains. And that's actually my mentor, Dr. Roberta Diaz-Brinton, who came up with this definition. She's been studying estradiol for brain health, I'm going to say for 40 years. I mean, she's one of the pioneers in our field, at least. And she was impressed at the range of functionalities that estradiol serves in women's brains. And why is that? Because estrogen alone is not nearly as important as the combination of estrogen with an estrogen receptor. The way the hormones work is that they're like keys to a lock, where the hormone is the key and the receptor is the lock that you need to open for a million wonderful things to happen inside the brain and the rest of the body. And in the case of estradiol, women's brains are really full of estrogen receptors, like Sharon was saying. This is something that is genetically encoded, and we're born with a brain that is wired to respond preferentially to estrogen, any type of estrogen, but especially estradiol, which is the most bioactive and bioavailable hormone throughout a woman's reproductive life. What that means is that the brain is extremely sensitive. Women's brains are extremely sensitive to fluctuations in estrogen levels. And when you do have estrogen in your brain, you can see in a petri dish, you can see with the brain imaging that your brain has more energy because estradiol is a neuroprotective hormone. It supports the immune system inside the brain. It's a neurotrophic hormone. It's like a growth hormone in some ways, not technically a growth hormone, but it has a neurotrophic plumbing component. It also improves blood flow and circulation to the brain. It pushes your neurons to work harder and burn more sugar and more substrates to make energy. And it has a lot more functionality. It's involved in neuroplasticity. It's involved in immune control. So it's like an orchestra conductor. I guess said a CEO in the book, because it's like this wonderful CEO who knows all the different aspects of the business, right? But then at some point, the CEO is tired and says, you know what? I'm announcing my retirement and I'm appointing Estrone as the new CEO. But Estrone doesn't have the vitality that estradiol used to have, doesn't know everything, it hasn't been as involved. And so the orchestra, if you will, keeps playing, but the tune is not quite the same. And a lot of women can feel these changes. And like Sharon was saying, many women are sensitive to changes in estrogen concentration throughout their entire lifespans. And when we go through the 3 Ps, puberty, pregnancy, and perimenopause, those are really pivotal times in a woman's life, but especially for a woman's brain. And we never look at the brain. We always think about what happens in your body. You're developing, you have a pregnancy, you have a belly, you have a baby, and then menopause, we always think about the ovaries. But in reality, the brain changes at each and every one of these Ps in a very similar way. Also throughout the menstrual cycle, like Dr. Malone was saying, whenever the ovaries cycle, your brain microcycles, right? And some women can be very sensitive to these changes, and women are less sensitive. But you can really see it, when you look at actual neurons, these proud little dendrites when estrogen is high, the connectivity inside the different parts of the brain is improved, blood flow is improved. And when estrogen recedes, everything kind of comes down in a way. So it's really, at puberty is when this connection between the brain and the ovaries is activated. And we know what happens at puberty, right? You're bracing yourself for it. Sharon could talk to us about puberty for a very long time. But we know that teenagers, are spacey. They have changes in temperature regularly, start sweating a lot, right? The glands are differentially activated, and then they have the brain fog, they have the mood changes. And we see that again in pregnancy. Some women have the baby blues, some women have postpartum depression. 30% of pregnant women have hot flashes, right? But we don't we don't think of that as a downside. We just think of all this as part of going through puberty and having a baby is a cause for celebration. Menopausal women have similar symptoms. They have hot flashes, they have mood changes, sleep disturbances, brain fog. But now we associate that with a downfall. And I think that's very unfair to all women, that we have such a negative view of these symptoms as a catastrophe rather than something that happens that deserves attention and treatment whenever necessary. But it's also just part of this transition where the brain is remodeling because of changes in hormonal concentration. So there's a reason for it. That's what I'm saying. There shouldn't be fear around them. There should be knowledge, and with knowledge comes action and self-care.
It's just fascinating. I mean, I was really floored by the pruning of the brain as well. As predicted, we have a ton more to talk about. We have questions flooding in, and I want to try to ask you both 2 more questions, but I want to also make sure that we get to our audience questions too. So I think I'll skip straight to sort of 2 of the biggest fears that we hear at Alloy, and that both of you have heard in your work. Around menopause and its treatment, because as we have been sort of talking about, when your body stops making estradiol and estrogen and progesterone, there's all sorts of suffering, and it doesn't necessarily need to happen, the suffering, and the first line treatment is this hormone replacement therapy. But 2 fears about that. One has been around for a while, one has arisen more recently. Sharon, there's still a persistent fear that estrogen and hormone replacement therapy causes breast cancer. I know that is a giant rabbit hole we could go down, but could you give us a couple of top line headlines there about, should we be afraid of hormone therapy for menopause causing breast cancer?
No, I think that it is safe to say that estrogen does not cause breast cancer. There's no evidence that suggests that it does. However, we all know there is a study, the Women's Health Initiative, which really cemented that notion in women's minds. There is that fear of breast cancer has really been determinative in the past 21 years as to why women have turned away from hormone therapy in droves. And it is the fear of breast cancer, which is overblown at best and non-existent in other cases, where I think that has driven women away from not only the most effective treatment for menopause, but also has taken out of their armamentarium the things that for prevention. You know, estrogen is important for maintaining bone health and preventing osteoporosis. It does help with brain health. Now, what we do know, and let's back that up a little bit, we know that for women who have early menopause, which means menopause before the age of 45, or premature menopause before the age 40, those women are at higher risk for developing Alzheimer's disease. Now, do we have the definitive proof? No, but that's what Dr. Mosconi is working on. And it is unfortunate because that one study, the Women's Health Initiative, has really stymied research and getting definitive answers to those questions. But let me say, it's always going to be, you know, risk benefits. The risks of hormone therapy are small. The benefits are great. It matters. Timing matters, you know, in terms of increasing the benefits and decreasing the risk, absolutely. But there is no time at which I think that women cannot, with proper guidance, decide and make decisions based on their own personal health and their treatment goals and their own personal health risks. So I think that we have unfortunately lost a generation of women and a generation of doctors who were actually educated about menopause, and we have let fear sort of dictate what has happened in these past 20 years. And that's really what we're trying to get back to, is to get women to understand that estrogen is not your enemy. It is certainly something that is the most effective treatment, and that women should educate themselves. And in certain instances, you may have to educate your doctor, but you may not have time for that. And that is why Alloy exists, because we want every woman to have the information that they need so they can make decisions for themselves. So we preach for education and for agency, because, you know, again, it's unfortunate, but here we are 21 years later, and we're still living with data from, you know, 2002. So if I had to say, that's the message that I would like to get out there for women, is that, you know, again, do not be afraid, and certainly do not let the fear of breast cancer be the reason that that stands in the way of your getting the help and the relief of symptoms that you may need.
So much to talk about, and some of these questions, I'm just looking through the audience questions, are so good, so we're going to get to as many as possible. Dr. Mosconi, as you know very well, one of women's biggest fears at this age is also Alzheimer's, probably with good reason, right? Aren't women two-thirds of Alzheimer's patients, right? So we are more likely to get it. We're terrified of it. We have brain fog symptoms in perimenopause and menopause that make us think we're getting it. So much to ask, like what we can do to prevent it. However, what we've heard recently is this fear about hormone therapy and Alzheimer's. Can you sort of unpack that for us?
Yes, happily. And yes, it's something I've been dealing with for a couple of years. And you know, every day there's a new headline, and it feels like people are really determined to prove that there's something wrong with taking hormones, and I'm not sure where that's coming from. But when it comes to Alzheimer's disease, we and others have shown that menopause can be a risk factor for developing Alzheimer's disease for some women. So what is a risk factor? What is a cause of disorder? Something that causes a disorder makes you sick. A risk factor may increase your risk, right? So it's like if you have blue eyes, you have a higher risk of being damaged by the sun unless you wear sunglasses. That's a risk factor. So menopause acts in a similar way, in that it puts the brain in a vulnerable position for some time, during which, if you have a predisposition to Alzheimer's disease or to other disorders, that predisposition may materialize as something measurable. Like we can see Alzheimer's plaques appear in women's brains as women start perimenopause, not after the last menstrual period, prior. So is it every woman? No. At the end of the day, about 20% of women develop Alzheimer's disease, which I think is too much, but this is the pushback I get all the time. So I'm just going to put it out there. It's only in quotes, 20% of women who develop Alzheimer's, 80% do not. So clearly there's other factors at play. Now, could we legitimately reduce the risk of Alzheimer's disease by taking hormones during the transition to menopause and afterwards to protect our brains? The vast majority of scientists I work with would say, yes, that makes a lot of sense. But then when you go and look at clinical trials and other studies, the evidence is mixed. And just recently, there's this group in Denmark who decided to terrify everyone by showing that in their cohort, there was an increased risk of dementia, not of Alzheimer's disease, of all-cause dementia, for those who were taking hormones before the Women's Health Initiative, so in the early 2000s. And those women were taking high doses of conjugated equine estrogens, often enough with a synthetic progesterone. So it was a very specific type of hormone therapy, which is different from what is most widely used today, like a low-dose estradiol, preferentially transdermal, micronized or bioidentical progesterone. So it's not the same. And I think it's very important to realize that formulation seems to have an impact. What also seems to have an impact is timing, which Sharon was talking about before. So what we had done for peace of mind is that we've done a meta-analysis, which is a statistical integration of all available data. So we have more than, I think it was more than 6 million women in the analysis at this point, and I can check, but there was a lot of studies. Well, all the good studies were included in this evaluation. And what we have shown is that for women who start hormone therapy in midlife, in response to the symptoms of menopause, then the risk of future Alzheimer's disease, but also all-cause dementia, but specifically Alzheimer's disease, is actually reduced, especially for women with surgical menopause, which is exactly what Sharon was saying. Now, when you start taking hormones after midlife, which is like more than 10 years after the final menstrual period, then the studies are all over the place. And in general, estrogen-only therapy for women without a uterus has a neutral effect, whereas estrogen and progesterone therapy, if you start it more than 10 years after menopause, sometimes it's protective, more often it's not. And these studies are basically the Women's Health Initiative and a bunch of studies that were done at the same time. So just to piggyback on what Sharon was saying, I think it's really important to have this information because it looks like maybe professional societies did not have an integrated view of all the different studies. But I assure you, they are confusing. They're really confusing, and it's very complicated to pull them together, which took us quite a little time. The statistician was like, oh my God. But the results are quite encouraging. And I think they really speak to the need for more research so that we can have even cleaner clinical trials. Also, one thing that I really resent is that all the information we have looks at hormone therapy taken now, and the endpoint is whether or not a woman develops Alzheimer's. This is something that in my field, nobody's doing anymore. We stopped doing that in the early 2000s because that is just, how do we control for everything else that happened in those 30 years between midlife and late life? So what we are doing now is we're using brain imaging. We're using biological markers of Alzheimer's risk so that we can check whether hormone therapy in midlife has an impact on your brain in midlife. And I'm hoping to see, we're doing a clinical trial now too, actually. And I'm hoping to see a lot more research blooming in my field.
And this is
fascinating.
Another way that, and we keep coming back to the Women's Health Initiative because that's still where the bulk of this information came from. But it also, we cannot underestimate the impact that it had because in these, 30 years since the study started and 20 years since they ended it, imagine if we had the data for those women and that they had not stopped the study, because there are a huge number of those women who would have continued to take their hormones, because when they stopped the study, the women who were in the study threw them away for the most part. And imagine now if we had 30 years of cumulative data of women who had stayed on their hormones, and we'd be able to answer some of these questions. So that's the unfortunate thing. And Lisa is absolutely right. We don't have another 30 years to answer that question. We're going to have to come up with more innovative ways to get to that answer without saying, well, let's start at 50 and I'll check back in on you at 80. That's not going to happen.
No, it's not going to happen. You know, one more thing we've done is to also look at brain fog and whether hormone therapy may help with the cognitive changes that women experience during menopause. And once again, the reason that I don't do meta-analysis, you know, I'm a brain scientist, but I felt like I had to. Because every time I say the hormones may also help at least some women with brain fog, then what I hear is, where are the clinical trials? I said, but we had the clinical trials. But again, one trial says yes, one trial says no, one trial shows nothing. And so we did another integration. It just came out a month ago, I think, and I can share it in the link in the chat if anybody's interested. And we're showing the hormone therapy can have a positive effect on cognition. Again, if taken in midlife, and the impact is more obvious in women with surgical menopause. But that, I think, is a problem with cognitive testing, because the range is like 0 to 10. You know, if you go from 10 to 9, is a big change to you, but statistically, it doesn't really matter that much. So I really want to see brain imaging in there. But I think
Okay,
it's
well, I think
about brain fog. Yeah.
No, very, very important. And I think everyone would love if you could drop that link in the chat if possible. It doesn't take you too far away from our conversation, because I do think you guys really do need to take this on the road. I think the combination of your expertise is just so valuable, and we can tell by all the questions, which I'm going to get to. I was going to ask you both, because you both have this wonderful positive database, but positive and optimistic take on menopause and this whole phase of life that comes from your years and years of research. I wanted to get there too, but I think some of these questions go straight to the heart of what we're talking about. So I thought I know we only have 10 minutes, but I'd like to just read a few of these. Here's one I think is very relevant. I am 46 and I'm likely in perimenopause. I have several of the neurological symptoms. However, they haven't been bad enough, per quotes, to look into HRT yet. However, my mom has late-stage Alzheimer's. Could starting HRT now, I have a uterus, help lower my risk of developing Alzheimer's? Also, my dad has Parkinson's, yet another reason for my interest to protect my brain. Thank you.
You know, there's the FDA-approved, professional societies approved answer, and then there's the answer I would give a friend. And I'm only allowed to give you the official answer, which is that we don't know.
And then there's the
maybe
other.
Sharon can say something more.
And then I'll say it. You know, I can say whatever I want to say. It's just me, right? Asking for a friend. I will answer for a friend. Yes. I mean, I would. Let me just say, even if you look at it from the standpoint, and that's the other thing, that women feel like, I'm not suffering enough yet. A little bit of suffering is too much, if you ask me. So there is no point at which you say, well, then now I'm totally not functional. Now I'll start it. No, I think you should start it when you experience symptoms and you are bothered by those symptoms, you know, because you don't get a medal at the end for having endured for 5 years and say, now I'll start it. You know, and I will say this, I will tell you what I know and I'll tell you what I think. And this falls in the category of what I think. I think that for women who are symptomatic, and we know that there is a window of opportunity in terms of what's happening to your brain, then it makes sense to start whatever intervention while your brain is undergoing that change. But let's be clear about it. Everything that we're talking about here is done in conjunction with the lifestyle interventions that you need to start instituting early in life. I think that we don't spend enough time talking about prevention on the front end, and we spend too much time talking about treatment on the back end. And that's too late. If, you know, Lisa says that your symptoms are going to start, you know, your brain starts reorganizing 10 years before you get to menopause, you know, that sounds reasonable to me. And so, no, do we have an FDA approved indication for that? No. Would I do it for that reason? Yes, I would. So I hope that's
And not
helpful.
being a doctor at all, but just having listened to you even just today, forget about the 5 years I've been spending. If I were 46 in perimenopause and my mother had Alzheimer's, I would 100% start taking HRT.
What's also important, I think, to mention is that it takes a long time for any research to really turn into a clinical guideline.
Right.
So the question is, what's your timeline? Because we know that the research is published today, and there needs to be a certain amount of research for professional societies or the FDA to even consider doing another review. And then it can take over 10 years. 17? Sharon, is it 17 years that it takes?
Oh my God.
Guidelines to be updated, something like that,
it's,
between 10 and, it depends on what we're talking about, but it could take over 10 years, right? And what do you do if that's your window of opportunity? So I think that's a question that nobody can answer necessarily, but for me, I'm trying to push for I'm doing a lot of the research because I would like to have the answers for myself, for my daughter, for my friends. And yeah, I wish things could move a little bit faster as well.
I'm very aware that a lot of these questions are very specific to one's own health situation. And just want to say this is not actual medical guidance that we're giving here. This is an educational conversation. And I think for the very specific ones, I'll just put a plug. If you would like to join Allo, you have access to an MD who can answer your questions throughout the time that you are a subscriber to Alloway. So I think I'm going to skip some of the very specific ones. I thought this was an interesting one. Do you think brain scans might someday be protocol as a regular screening for perimenopause and basic brain health?
For perimenopause, no.
What were you saying yes to?
I would love for brain imaging to become part of preventative evaluations for women when there is an indication to do a brain scan. It can be every person, but we're dealing with this right now because I run the Alzheimer's prevention clinic at Weill Cornell Medicine, and a lot of women come to us with brain fog, which is a very non-specific symptom, and many would love to have their brains checked. I would, for sure. And sometimes we're able to do a brain scan and charge insurance, but let me tell you, it's not easy to do that. And I would love to have more CPT codes. I would love to have a little bit more flexibility and more indications that we can work with, because when we do the brain scans, it's extremely helpful. And often enough, there are things that can happen to your brain. It's like an organ, like any other organ, that may need attention. Like Sharon mentioned, the white matter hyperintensities, right? For women with hot flashes. This is something I would like to check if I'm having severe hot flashes. The brain fog, what is it? Where is it coming from? So we're looking at it right now. But if you're coming for an Alzheimer's evaluation, even for prevention, we need to be able to exclude at least a number of things that I can't do unless I see your brain. So I'm hoping in the future we'll be able to do more preventative brain imaging, because I think there's value in that. I mean, within reason. But yes, I would like that very much. I think a lot of people would really like to see their brains as well. I think it's very motivating in terms of self-care and feeling better connected to your head. And the relief. When we tell women who are extremely worried, they have brain fog, they have hot flashes, they have a family history of dementia, and we do the cognitive testing and we do the brain imaging, and then we tell them it's just menopause,
Right, just, that's all.
The relief is enormous. Obviously, it's just menopause as far as we can tell within this specific research, blah, 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 blah. But you know what I mean? There's no reason to concern at this time point. Right. And the relief is just huge.
Right. It's menopause, and we know how to treat menopause, so.
Sharon, can I ask just a couple of questions about hormones?
Relief is, and then we send them to Abigail. Yes.
We know how to do that.
And get them on hormone therapy. Okay, a couple of questions about hormones that I'm going to combine here. Is estrogen the only important hormone for HRT, or is it best also to balance it out with progesterone and testosterone? And then related to that, the ovaries turn off, but don't the adrenals continue to produce estrogen and testosterone?
Okay.
Sharon, do you want to start?
Okay, I'll start with that. Yes, if you have a uterus, then you should take estrogen and progesterone, but the progesterone's purpose is really to protect the lining of the uterus. The active hormone for most of what we're talking about is the estrogen in the estrogen component, in the hormone therapy component. Yes, and our ovaries do continue to make testosterone at lower levels. And we don't know as much about testosterone, but we do know that obviously it does have a function, not only just in women's bodies, but in brains as well. And we're a little bit behind on that. So we're just getting up to speed on what role testosterone has. That'll be Dr. Mosconi's next line of study of what testosterone does to women's brains. But, this notion that you switch over to your adrenals, well, your adrenals do what adrenals do, but they don't really have a huge role in the estradiol or production after menopause. It's a minuscule amount. So no, it's not like you have a switch and you get another unending supply. But there is a small amount. And as Dr. Mosconi said, our main estrogen changes over. It's not estradiol that comes from the ovaries, it's estrone, which is a much weaker estrogen. And so, yeah, I wouldn't think of that as a major source for women after menopause.
Wonderful. And every time we do one of these, the amount of questions just floors me because there's so much more need for this conversation and education. This is a great one for you, Dr. Mosconi. What is the biggest difference in the brain between women who have had children and those who have not?
Oh, that's interesting. So the brain rewires itself once you're pregnant. And the changes that have been noticed are quite interesting in that the gray matter kind of shrinks a little bit, which is not the best term because it implies that there's something negative about it. I would say there is a reduction in gray matter in some parts of the brain, but there's a strengthening in connectivity in other parts of the brain. And the way this has been interpreted, or at least let's say this is what I would say, this is my theory, is that puberty, pregnancy, and perimenopause are all biological clues for the brain to get leaner and meaner, if you will, because our brains are huge. And the more neurons you have, the higher the metabolic expenditure and the more oxidative stress that your organ will experience. So it makes sense that when you don't need certain neurons, you just get rid of them, but you make sure that the other neurons are stronger and more protected. And that seems to happen during pregnancy, where the brain network that is responsible for instincts, for being able to work with, to just function on zero sleep, stamina, endurance, but also theory of mind and empathy are all improved in women who are pregnant and then postpartum for sure. So there's a rewiring that's been called the mommy brain that is associated with pruning. We do lose neurons, but there seems to be an evolutionary adaptation or an evolutionary reason for that to happen, which, yes, it will give you the mommy, it may give you the mommy brain, you may forget things, you may feel depressed, but at the same time, it's your brain's way of preparing you for motherhood and really supporting you by heightening those instincts that will make it possible for you to be a successful mother, which in evolutionary biology means make sure that that little human doesn't die or survives effectively. So, yeah.
And so would you say, in
terms of
speculation,
who knows? I mean, we have found that the more children a woman has, up to 4, the more gray matter you actually have complexively in your brain, or the bigger your brain is at the end of the day over time. So there seems to be some kind of protective association. There needs to be studied better, though.
So would it follow that women who never become pregnant don't experience that pruning and therefore their brains remain unpruned, larger?
Yeah,
I don't know.
Until menopause. That's the theory, yes. But I don't think there's a lot of research that can really tell you, yes, that's 100% the case or not. I think we need more work.
Yes, I think that's the answer to so many of these questions, right? More research.
Turns out, and you lose a little bit of gray matter. It's not like your brain loses a ton of neurons, just to be clear. Just some parts of the brain get a little bit thinner, but better connected.
Right.
Yeah.
Can I make one quick plug before we go? And this is why it is so important that we as women individually and collectively advocate for more research, because we still are trying to answer questions that we've been asking for 30 years. And, you know, to be able to support researchers and women and diverse researchers who are out there trying to answer these questions, because I think the only questions that are going to be answered are the ones that are asked. And I think when you have people out there like Dr. Mosconi, Dr. Howard Hodis, and there are a host of other researchers who are really not being supported, I think it's time for us to speak up. And I think that we have to start to demand, as women, as 51% of the population, that it's time to answer these age-old questions that we've had for time immemorial. So that's it.
I love it. I think we have to leave it there. It's 12:02. I promised Dr. Mosconi she'd go back to her 12 o'clock work. But we're so thrilled you're all here. So many important questions have been brought up. So many we didn't get to answer. This will be recorded. This has been recorded and will be on YouTube. And feel free to reach out to any of us at Alloy with questions. The books are Grown Women Talk, Woman Talk, and The Menopause Brain. And a lot of your answers are in both those books. Thank you so much for joining us. Thank you, Dr. Mosconi. Thank you, Dr. Malone. And we hope to do this again soon.